it and how we do it, and what are the outcomes that we expect after that. So today I'm going to try to teach a little bit about everything you need to know about coronary artery bypass surgery. Definitely, it's an operation that that has been very well studied. Is one of the most common procedures in cardiac surgery. It's the most common procedure that we do these days now for cardiac surgery, and there's probably no other procedure that has had an impact on survival and on symptom relief over the long term in the history of modern surgery for us. And it's also one of the most heavily scrutinized and standardized, regulated procedures out there because it's so important, has a lot of impact. So that's why it's important for us. So I kind of wanted to give a little bit of an overview of what we're going to do today, and just going to go over a little bit about some data like statistics and some epidemiology. And also going to kind of explain to you what is coronary disease, because that is the main reason why all this is done, all right? And also then we're going to talk about specifics about what is exactly coronary artery bypass surgery, and also what techniques do we have available for us to perform this operation. There's many ways to do it. There's many ways to arrange the configuration. How do we plan for it and all these? And also to identify which patients will benefit from one or other intervention, right? Because sometimes the surgery is not suitable for everyone. Then we're going to talk about the outcomes, what to expect after you get through the surgery, what the recovery will be like, how much time you're going to spend in the hospital, if you're going to need rehab or not, and all these things. And then the follow-up long-term, like what we do going forward. So, just kind of wanted to start talking about overall heart disease, and then here in the United States, and all these data is from the CDC. So it's the leading cause of death for men and women in the U.S., and it's also the leading cause of death in developed countries, Europe, Israel, and all these countries. Why? Is because mostly it's because of the lifestyle that we have, and also because of some genetic factors involved into it. And then we know that it's so common that one person dies every 36 seconds from overall cardiovascular disease in this country. And overall, over 500,000 people die from heart disease every year here in the U.S. And it's not only, the loss of someone that or it happened to yourself, but it's also, has a big impact in the society as well. There's a very heavy economical burden from heart disease, which is mostly related to the productivity of that person, or like the medication that person needs to buy to kind of stay, cope up with the symptoms or with the recovery of any intervention. And we will see that it's also a disease that can be present in young people. So let's imagine you're 45 years old, you have coronary disease, and for some reason you're disabled, you cannot work. Imagine that's probably 20 years of productivity lost right there, which has an impact overall in the society. So that's why it's important, and is heavily investigated, all these, because of the impact in the society that it has. So kind of going by demographics here, and then kind of looking at where is more prevalent, heart disease death, because that's what is the ultimate outcome is that we're looking at. And then we can see here most, kind of heavily areas are mostly in the South, kind of a little bit, in the Midwest here, and a little bit, to the West, and also in the North of Alaska. So most of this distribution is related. Why? Because number one is social factors, either diet, access to healthcare, and specifically for people that live in northern Alaska, is mostly related to some genetics. So we have found that population of this patient have increased propensity to have heart disease overall. So that's kind of why the distribution kind of looks like this, and so it kind of explains to us in which areas, so weird geographical areas in the country, we have to pay more attention to, because it's the ones that are more affected by it. And we know already that the outcomes are different depending on your race, depending on your age, depending where you live, depending on your socioeconomic status, because not everyone has the same access to healthcare, not everyone has the same social support, family support. home. So all these things play into role about the outcome of this disease. Specifically, coronary disease is a type of heart disease. So, which is kind of the main reason why we are here today. So it's the most common type of heart disease and is responsible for a lot of deaths just in 2017. Like I said before, it's not only a disease that sometimes we think about it, it's like, if we think this is a disease that happens only in the elderly, that is not true. We have had patients that are young in the late 30s, early 40s that have coronary disease, and if you don't take care of yourself, or if you have bad genes, it doesn't matter what age you have, and we know from pathological studies that there's evidence of fatty depositions in the arteries as young as 10, 12 years old. So that's why it's so important to tackle this from an early age through education, lifestyle changes to try to prevent this in the long term. And, like I said in here, about 20% of the deaths from coronary disease happen in young people, younger than 65 years old. So it's a disease that has a wide spectrum of presentation. Yes, it is true. It is mostly associated with advanced age, but we are aware now that it can affect many different populations as well. So now heart attack is a consequence of that. So heart attack is very common. There's data out there saying the heart attack happens every 40 seconds here in the U.S. And then almost 1 million people in America have a heart attack every year. Now, the most important thing is that sometimes this is not only like, I just had a heart attack and it's not going to happen to me again. I took care of things, I take my medication, and that's it. But we know that you can have recurrent heart attacks if the problem is not fixed, if the blockage is still there, if your heart is still diseased. So that's why it's important to pay attention to it at the beginning and to kind of try to minimize the consequences, because every time your heart gets a hit, it becomes weaker and weaker and weaker. And we know from biology that the heart muscle doesn't regenerate. Like for the liver, for example, you can take 85% of the liver in someone and it's going to grow back to 100%. For the heart, you lose one cell, that cell is gone forever. So it doesn't recover. So that's why, sometimes we have patients that come here, they say, we had a heart attack, I'm taking my medication, keep doing my thing. But if you don't change your lifestyle, if you don't change things you do, it can happen again. And the most important thing is that about 20% of the people that have heart attack don't know they had a heart attack. Why? It's because the symptom presentation is different. And in some cases, for example, some patients may just have abdominal pain, or they may just have nausea, for example. And that can be a presentation in a specific patient population, for namely sometimes diabetics. So what happens with the diabetes? The diabetes basically causes a damage in your nerves. So some of the sensations are lost. And that's why when you're supposed to feel pain, you feel other types of sensations, or you don't feel pain at all. So that's why we are very cautious with diabetic patients, because these people can have heart attacks and may not know it. Also, other types of patients may have these and they may confuse it with something else, or an anxiety attack, or blood clot, or I just had a bad flu and I've been coughing, so my chest hurts because of that. So that's why it's important to kind of dig very well into the story. And then we also have means in the hospital and the clinics to diagnose this. Namely, it will get diagnosed by blood work, it will be diagnosed by something we call EKG, which is electrocardiogram, which we will kind of connect you to little electrodes and run a picture of the electrical system of your heart and see where it's not passing kind of current through, or where is the difference in that, and that's how we know. So it's always too important to see that. So then we talk about heart disease, and then we talk about coronary disease, and then we talk about heart attack. So all these terms are kind of a little bit confusing. So like, what is what? Why is so many different terms for all these things that is happening? So overall, I just want to kind of bring you an overall picture. So we have the heart, and the heart has different types of disease. So the most common one, which is the one we're going to talk today, is coronary artery disease, right? which is the blood vessels that go on top of the heart like this, and then they get disease for various reasons. Also, you have valves in your heart that can get disease. Also, you can have abnormal dilatation of some of the blood vessels in the heart, namely aneurysms. Also, there's the electrical system of your heart can be damaged. We call that arrhythmias. Also, the muscle of your heart can be damaged. We call that cardiomyopathy. Can be inflammation, can be infection. So there's many types of heart disease, but one of the types of heart disease is coronary artery disease. All right. So one of the consequences of coronary artery disease is heart attack. So that's why kind of to free up the confusion from that term. Yes, it's possible some people may have concomitant disease. For example, you can have a valve disease and coronary disease, or you can have abnormal in the rhythm and coronary disease, or you can have more than one combination. So it's a very complex pathology system out there. But specifically, so coronary disease, like we said, the heart, I always think about the heart like an engine, the engine of a car. So the engine of a car needs some sort of piping so the fuel can get to the engine can run and propel the car forward, right? So the heart, going to the analogy, the heart is a pump that continuously squeezes blood in and out for the rest of your body, but that pump needs fuel, and that fuel is blood. And the way it gets to your heart is through the coronary arteries that they sit on top, like this. Huh? So through a lifetime, because of genetics, because of some diseases, because of diet, not exercising, the normal lining of the blood vessel, right? When we have excess fat or damage in the blood vessel, it starts accumulating on the side of the blood vessel, all right? So that stays there for a little bit. And then if we don't change, if we don't modify risk factors, this is going to continue to grow bigger, and it's going to start limiting the blood flow coming through. And there's one good day that is going to be like a little plaque, a little erosion here, and then the cells that act like the policemen of our body, they're going to say, oh, there's a little injury there. Let's go there, everyone, and try to fix it up. So they come in here, they all aggregate together, and then they block it off. So that's how coronary disease progresses. So it's a combination of damage to the lining of the blood vessel, fatty deposits, and accumulation of cells that cause inflammation. It's like a cycle that repeats over and over and over. So if you see a cross-section of the coronary arteries, you will see that you will have normal blood flow. And then here, as the plaque starts growing, it starts narrowing the lumen. So you see here it's like at 100% okay, then here starts getting narrowed. So now the blood only can go through this little bit, all right? So there's ways for us to measure how much blood is passing through, how much resistance is to that blood flow, and also where are the lesions located. So those are all tests that can be done by your cardiologist, and we will examine the test together. In general, we will diagnose coronary disease when you have more than 50%, when half of the lumen is occluded, we'll call coronary disease. And when it's more than 70% occluded, we will call that severe coronary disease, which is going to take us to, once we talk about in the next couple of slides, about the indications for the surgery. So when you have severe coronary disease, which is more than 70% blockage, that's when we consider intervention. Or there's one artery, which I'm going to show you later, that when it has 50% only, because it's a very important artery, then we have to proceed and intervene on that. And of course, if you have a patient that has symptoms that hasn't reached the limit for the degree of blockage, sometimes we will consider those patients for intervention as well. So what are the risk factors for coronary artery disease? Namely, number one, high blood pressure. Why the high blood pressure? So imagine your blood vessel is a pipe. So through that pipe, you have a certain pressure that pipe, can withstand. If that blood pressure is for a prolonged period of time high, is kind of going to cause microscopic damage inside the lumen, so inside that little endothelium. So when you have that microscopic damage, there's, like we said before, there's inflammatory cells that will come through and they say, oh, let's come here, let's try to fix this. And they all start accumulating, and that's how your plaque gets formed. Second is the cholesterol. So there's two types of cholesterol. We all know as a good cholesterol and bad cholesterol, right? So what does the good cholesterol do? Basically, the good cholesterol takes the cholesterol either from your diet or from your body and brings it, outside of the organs to be metabolized by the liver, so it can be used as a fuel for all your requirements in your body, right? Then there's the bad cholesterol that is riding in the opposite direction. One goes this way, the other one goes this way. That is going to take all the excess cholesterol that we are not using, taken to the organs for storage. And that's how when you have an excess of that, and there's nowhere else to put it, right? So then we have to put it on the side of the road, which are the coronary arteries and other vessels in your body. Smoking. Why does the smoking causes coronary disease? Mainly because the smoking damages the lining of the blood vessel. And in smoking, what I have seen is one of the highest risk factors for developing overall heart disease and specifically coronary disease, is because the smoking has components in it, has chemicals that damage your walls. So I tell my patients, if you're gonna go through surgery, right? If you're gonna go through surgery, my expectation is that the repair that we will do for you is gonna last you many, many years, more than 10, 15 years, all right? And in medicine, we never say never, and we never say always. But there's only one thing that I can guarantee. If you continue to smoke after the surgery, for sure, whatever we did on your surgery, whatever bypass we did, is gonna go down the next day, all right? So you went through all the surgery, through all this trouble, through all the recovery for no benefit. So smoking is a big, big factor for us. It's very important. It can affect your wound healing as well. Now, diabetes. What's the problem with diabetes? Diabetes basically makes your body unable to store glucose. So what does the body do with the excess glucose? It converts in a way that it can store it easy. So it's going to get converted into fat. So then this fat, going back to the excess in your body, is going to get deposited somewhere. It's going to be one of your blood vessels. So diabetes is a big, big, big causing agent. So imagine if you have a combination of the first four, right? Which is very common to have. You can be diabetic, you can take care of yourself, then you smoke, then because of that, your blood pressure is going to be high, your cholesterol is going to be high. So you have four factors right there fighting to make you feel or to not let you be healthy. Now, overweight and obesity. Overweight and obesity, they play a role, because usually these are linked to the above factors. Usually they are linked to high blood pressure. Usually they are linked to high blood cholesterol. And in general, usually it's linked also to some types of diabetes, all right? So overweight and obesity are major problems in our society these days. And most of them come, number one, because of lifestyle factors, right? Either we have an unhealthy diet. We all know what are the right things to eat. We all know when we go to the supermarket, if you have to make a choice between, one type of bread and the other type of bread, we know which one is best for us. We know the vegetables are best for us and fruits are best for us, right? But sometimes we say, maybe it's just easier just to, to have bacon, every day for breakfast, So instead of having, for example, oatmeal, so we all know what unhealthy diet and what healthy diet is. So those are main causating, factors. Physical inactivity. Now, this is a big, debate. People have debated, over a long time. What is the recommended amount of exercise that we should do every week? Some people say 30 minutes 3 times a day, 20 minutes 5 times a week, and so forth. But I always tell my patients, even, if you get up and you go walk around the block a couple of times, twice a day, you should be good. Because sometimes we know that sometimes you have some medical conditions that don't allow you to perform, at a high, exercise level, or or you have other medical problems, but it's best, to at least go for a walk than to be, sitting without exercising, right? So physical inactivity, unhealthy diet lead to obesity, which usually is linked to diabetes, cholesterol, blood pressure. And one factor that sometimes people don't talk about is excessive alcohol use. Why? It's because number one, alcohol use, besides that it has damage to your organs, right? It can damage your liver, which can impair your ability to metabolize fat and metabolize glucose, but also is usually used in conjunction with other recreational activities like smoking. So you see very commonly that you have people that drink alcohol and then they smoke at the same time, or people that drink alcohol that don't eat healthy diet, don't have physical activity, and then they are obese as well. So that's why we keep all these things together. These have been very well studied over many decades as the main leading causing factors for this. Are there other factors out there? Yes, they are. There are some other genetic mutations that you can be born with that can contribute to coronary artery disease. And there have been also, some other genetic factors. For example, if you have family that have early coronary artery disease, we know that sometimes even with lifestyle modifications, these people will tend to progress to coronary artery disease. And also some other subset of patients, for example, if you have a patient that has a history of radiation to the chest for whatever reason, in general, most commonly cancer, the radiation can also damage your coronary artery. So those are other like a less common factors for this, but it's very common. So how will you know, like if you have coronary artery disease? Some people will experience chest pain. Some people will have some shortness of breath, and mainly you will notice when you're doing some sort of extra physical activity, like you are there gardening, or you try to go up 2 flights of stairs and you cannot go up 2 flights of stairs, you start getting chest pain. So then those are kind of symptoms to be in the lookout for these things. Some people, they say, I don't have any shortness of breath, I don't have any chest pain, but my legs get swelling all the time. So what would that be? So it's possible that your heart is weak because of coronary disease, which is causing you to retain fluid. So those are kind of out there many ways that this disease can present, and it's very common out there. I can have it, all my family can have it, and you won't even know it. But we all know what the day-to-day, what are the right things to do, what are the right things to eat, what the physical activity we need to do, so we can do little things, changes, to improve our lifestyle. And I always tell my patients, you cannot, if you try to do many changes at the same time, it's probably not going to be successful. So I always say you need to start small with one little change. The next month you add something else, and then you add something else the next month, and then that's going to be easier, right? But it's very hard to stop and change everything one day from the other. So when does a heart attack happen? So now we know you've been with coronary disease for a couple of years. It's been slowly building up. We keep smoking, not taking care of the diabetes, not doing exercise. So the plaque starts building up more and more and more, right? So eventually this plaque is going to rupture, all right? So it's going to rupture because it's getting erosion. It's like when you have a waterfall, right, hitting on a rock constantly, over some period of time, it's going to cause an indentation in that rock. So the same concept, you have blood passing through that same plaque, air constantly, all the time. So it's going to erode the plaque. So it's going to get a moment where this plaque is going to break, and then there's going to be a little exposure there. So like I said before, then you're going to have all these policeman cells from your body coming together trying to fix that problem. And then that's when a blockage happens, then you get a heart attack, okay? So when your heart attack happens, there's no blood flow beyond to that area of the heart where your heart attack happens. So then you're going to have either a dead muscle if you don't restore it in a faster fashion, or you may have, some scarring creating after this. And like we said before, the heart muscle doesn't regenerate. So it's gonna stay like that for now if it's dead, all right? But there's time that we know that we can intervene. So usually within 6 to 8 hours of the intervention, we can still save the muscle after you get a heart attack. So what are the symptoms of a heart attack? Most of the time you will experience symptoms with chest pain. But like we said before, right? We said 20% of the patients are silent. Sometimes they just have a little shortness of breath. They don't even know it. Sometimes they feel nauseous. Let's say they have badly controlled diabetes. Or let's say they will have jaw pain or pain in the arms because of referred pain from the nerves, right? And there will be no chest pain. Or sometimes you will just feel dizzy because you're not getting enough blood flow through your brain and you don't know it. And some people will just have sweating. So the presentation can vary, but it's always to keep, all our antennas up in the lookout for this. All right. So I went to the doctor. I started having chest pain and shortness of breath, and my doctor did a study. Said, "Oh yeah, I have coronary artery disease. What to do now? What are my options?" So, namely, there's two options out there. All right. The first one that was developed is the coronary artery bypass grafting, which is the topic of our discussion today, which involves basically bringing the blood vessel beyond where the blockages are, bringing more blood flow down this way or down this way. And the other option is to do stents. Now, some people might find stents more suitable because it's less invasive and the recovery is faster. The downside of the stents is that if you have multiple blockages, it's very hard to do. And if the blockages are in not an area that is not easily fixed, they're not going to work. And also the long-term duration of the opening, we call it the patency, is inferior with stents compared to bypass. And also we have known from many studies that in a special subset of patients, namely patients with diabetes, multiple blockages, or a weak heart, having surgery decreases your chances of dying or having heart attack and having a stroke compared to stents in the long term. So what exactly is this that we're talking about? So once you get diagnosed with coronary artery disease, you will have most likely an angiogram, right? So the angiogram is a study that your cardiologist will do. Either they will access your wrist or your groin. They put a little catheter in there, go all the way up in your heart, and take pictures. Inject some contrast and take pictures. I have a picture of that coming up. So that's where we will identify the blockages, where they are, and then we will know how tight they are. We talk about the 50% or the 70% blockage and where are they, which location are they. And then from there, that's how we will plan the surgery. So basically the concept is that you're supposed to have 100% of the blood flow going down this vessel, okay? But then you have a blockage. It can be 70%, 75, 80, 90, it can be 100%, right? So our goal is to bring more blood flow beyond where the blockage is and provide it so it can go distal to it, okay? And you will say, so why can't I just go in there, open the vessel here, take out the plaque, close it up again? Why we don't do that? It has been done, it has been studied before. The reason it's not done is because the wall of the vessel at this level is already damaged. So even if you take the plaque out, the wall is damaged already, so it's going to just accumulate more plaque and it's going to block off again even faster. So that's why we know in the long term it doesn't work. So how do we make the connections? Basically, we're just going to make a little cut in the artery like this, and we're going to take a piece of one of the conduits we're going to use, which I'm going to show you a picture later. And it can be a piece of vein, it can be a piece of another artery from different parts of your body, and then we're going to suture that with a very, very, very fine suture that is even thinner than our own hair. And for that, we use special loupes that have a certain degree of magnification so we can see it. So usually for this, I will use probably 2.5x, which will be 2.5 times a magnitude, or 3.5. But some people test everything from 2.5 to 6, probably even more, but I don't think anyone does anything more than 4.5 magnification. Now, once we make the connection, how do we determine if this connection is suitable for us. Like, how do you decide, is this connection gonna work? Okay, so what we're gonna do is that we know well, the size of the catheter coming in is gonna be around 2 millimeters. All right, so that's very, very tiny. So we compare that size to the size of your normal arteries, and then we say, all right, so it's too small, so maybe it's not gonna work. Or we say, okay, it's about the same size as the catheter, so yes, it can work. So most of the surgeons are able to do this, let's say 1.5 millimeter size. So I think that will be kind of the lower limit. Have we done 1.25 millimeters? Yes, we have done, but not by choice. Sometimes you misjudge the size, but then you have to do it either way. But we have known that the bigger the size of your coronary vessels, the longer patency of that connection is going to be. So if you put it in an artery that is too small, it's not going to stay open too long because there's going to be a lot of resistance to the flow going through. All right. So it all started with a French surgeon named Alexis Carrel. So Alexis Carrel has a very interesting story. So he was born in 1875, give or take, and his father was worked like in a factory. He has a mother that she was in the house, kind of doing households. So his father died at a very young age, and then his mother had to do something to support the family. Now he has 2 or 3 little kids, so you got to work to bring bread every day. So the mother started doing embroidery. All right, doing embroidery and then selling her products, so that way she can buy food. So he saw his mother doing embroidery for many years, and he kind of started getting amazed about how precise she was and how how artistic it was, and then he just kind of had an interest for that. So when he went to study, he kind of took a keen interest for biology. So there's now 2 ingredients for this recipe that are being set on him, and then one day, after he graduated school, and then he became a doctor, the French president at that time got assassinated, or let's say got shot. All right, so he got shot in one of the arteries of the liver, right? We call the actually one of the veins. We call these the portal vein. So back in that time, imagine early 1900s, late 1800s, the only solution surgeons had to fix a bleeding blood vessel was to tie it up so it doesn't bleed anymore, right? You stop the bleeding. But in the portal vein, we know that if you tie it up, there's a high chance of you dying. So this is what happened to the president. So the president died because they tied up, which was at the time the only available treatment for this. So Dr. Carrel said, damn, man, we could have saved him. There has to be something else we could do. So he got into his lab, started developing techniques. How can I make a connection between a section of the blood vessel that has been cut, that has been damaged? So he started experimenting on that. And believe it or not, just by developing the technique to connect one vessel to another, he got a Nobel Prize in 1912. Now you will say, wow, get a Nobel Prize for that. Now that we do this thing, I did it 10 times in a case on Monday, right? But imagine, no one had a vision like he had back in the time. So everything started with him, right? So he was the first person who developed a technique to make a connection between 2 blood vessels, which paved the way for modern day either cardiac surgery or transplant surgery, right? Very important. When you transplant one organ to another body, you have to make the connections again. But what's happening is that cardiac surgery was not even a science back in this time. So it took 40, 50 years for us to have some sort of technology or some sort of thought process about how can we do cardiac surgery safely. So this is when Dr. Weinberg came through. Dr. Weinberg actually was the first person who thought about the idea of doing coronary artery bypass. So he knew from the work of Dr. Carrel that this thing could be done. Dr. Carrel worked a lot in animals because human studies were not were not approved back then. It was kind of a taboo. So what Dr. Abreu was doing basically just taking one leg off one dog, putting in the other dog, and then kind of interchanging the legs, making the connection, making them work. Dr. Weinberg said, why don't we do that in the heart? Because, we have people that have chest pain, and I know it after they die, we do the autopsy, and it's because there was a blockage there. And then so that's kind of how he developed the technique. But the first technique that he developed was not making a connection with one vessel to another vessel. He just basically took down the vessel and buried it in the muscle of the heart. And he noticed after 2 or 3 months, by doing studies, he will notice that there will be little blood vessels forming from where the blood was coming through. And that way it will vascularize that area. So that's kind of how it started. All right. So now we know what coronary artery disease is, what are the consequences, and how these came to be one of the most commonly done surgeries in the world. So how can it be done? All right. First off, we have to look at kind of the anatomy of the blood vessels, right? So we look at it and we see that the heart, like we talked about, is a pump that needs fuel to function. So you will have a left-sided artery, a right-sided artery that will supply your heart. There's one branch that will go in the front, like this, and one that goes on the left side to the back, to the side, all the way down. All right? The one here on the front is the most important one. Why? Because it supplies 2/3 of the muscle mass of your left heart. The left heart is responsible of pumping blood all the way up your aorta for the rest of your body. So imagine it needs a lot of fuel, right? So that's why it's so important. Now the right-sided artery comes namely on the right side, and then at some point these two, sometimes by microvasculature, they connect to each other, and that's how they envelop the heart and they complete the blood supply. So we talked about before about the angiogram. You see, so your doctor will come from below or from the wrist with a little catheter, which will be like this, all right? And then he's going to engage one of the coronary arteries, in this case, the left, and he's going to shoot some dye, and he's going to show the picture. So you see here how the dye is kind of uniform, goes in here, the size of the vessel doesn't change much. It keeps going, it's like, okay, right? And the same thing here. But then here, you will see that it narrows, and it's only like a fine thread, right? And then it becomes normal again. So that's where a plaque is sitting, and that's how we know what degree of blockage. We will call this probably 99% blockage, a degree of blockage, and that is called critical. We call this critical. So that's how we know from the angiogram what the severity of the blockage is, where it's located, how many blockages are there, and how can we fix them. And remember, we talked about the size before of the blood vessels. So just to give you, this is a zoom picture. So just to give you a perspective, this catheter is 2 millimeters, all right? So we know we can do something about 1.5 millimeter and above. So we will compare this size to this size, and we say, all right, that's a suitable target. We can do it there. But let's say you compare this size to this, right? No one will go after this because it's not gonna last anytime, right? So then that's how we know if you're suitable for bypass surgery, based on the size, based on the location, and the degree of the stenosis. Now, does everyone that has coronary disease have indication for surgery? Not quite. There are specific indications for the intervention. Number one, if you have someone that has triple vessel disease, what do we call triple vessel disease? We call disease in the front artery, we call the left anterior descending, disease on the circumflex, and disease on the right. So if you have all blockages in all three, we call that triple vessel disease, and that is an indication for surgery. Now, if you have two vessel disease, and you have diabetes also, which we know already that the diabetes can contribute to this and can make it worse, then that's an indication for surgery. Let's say if you have a disease only on this artery, this is very important artery, because if this artery blocks off, it's gonna nullify the blood flow to the whole left heart. So you're not gonna have enough blood flow going through your body. So when you have what we call left main disease, more than 50%, that's an indication for intervention. Or when we have what we call left main equivalent. What does left main equivalent means? That you have disease in the circumflex here, and you have disease in the left anterior descending. This also simulates as if you will have blockage here, and then we call that left main equivalent. Also, if you have multivessel disease and your heart is weak, let's say that the strength of the heart is weak, then you will have indication for surgery and so on. Also, if you have symptoms, right? Angina, chest pain, and all these. So what configuration can we do? In general, it will depend on your angiogram. We can make a connection with one of the arteries from your chest wall. We call it mammary artery. We can make a connection with one. We can make a connection with two. We can use a radial artery from your forearm. We can use a vein from your legs. So you can do one bypass, two bypass, three bypass. People call it triple bypass. We can make four bypass, 1, 2, 3, 4. We can make 5. On Monday, I did a 5 bypass. So there's many configurations, there's many ways to do it. And what grafts can we use? In general, either we're going to use the internal mammary artery, which runs on your chest wall. This one has been proven to last the longest. This one, up to 20 years after the surgery, you will have this graft open, all right? The right as well, about 95% long term. This one is not very commonly used, comes from the stomach, and we can just bring it out from the diaphragm, connect it up here. This is not very well commonly done because it's very difficult technically, and also it doesn't last long. Also, we can take a piece of the artery from your forearm, all right? Or most commonly, we will take a piece of vein from your legs, right? We will put a little camera, 0.5 centimeter camera in your legs, and we're going to take a piece of vein, we're going to divide it, and we're going to make the connection. So the selection will depend basically how many blockages do you have, where are the blockages, how tight they are, and your medical conditions. If you have diabetes, obesity, smoking, sometimes you're not a candidate to use these two. You will use only one. Or sometimes, let's say, if you consider in radial, then we will, let's say, are you a dialysis patient that have a fistula? Then we cannot use it. Or let's say you do heavy machinery work, you need your hands and all these things constantly every day, then we will not consider that. And sometimes you have patients that have, let's say, amputation or have thrombus in the legs that are not suitable to be used, or have varicose veins. So those are all the factors that we take into consideration to decide which conduit we're going to use. The most common configuration for us is going to be 3-vessel bypass. That is 60% of the patients. You will get one artery from your chest wall down to the main one in front of your heart, and 2 veins, one to the left side, one to the right side. This is the most common configuration. And we know from studies that this will last a long time. If you do a study 10 years after the surgery, in average, about 80% of the patients will have the vein will still good, and 90% will be still good here. And this one we know it's going to be good even 10, 20 years out, all right? So for us to do this connection, we have to kind of manipulate the heart a little bit. Either we will connect the heart to a heart-lung machine, which basically is going to deliver blood to your heart, and it's going to drain it, and it's going to go into a machine. It's going to mix it up and bring it up. And this machine is a simplistic example here, but this is what the machine looks like. It's a big machine with multiple pumps and wiring, and we have a special dedicated person in the back. It's called perfusionist. It's going to manage this machine our command during the surgery. So it's kind of a little bit of a waltz, of a dance together to try to regulate how much blood flow and all this. Well, we can do it without the use of any machine with a beating heart, right? We can do it with that. Or in some specific cases, we will connect the machine and do it using the what we call is a cardiopulmonary bypass machine. Also, another technique is that we can do it on a beating heart, but most commonly done in this country, we will do it with an arrested heart. What does that mean? That we're gonna put a little clamp here to block the blood flow to your heart. It's gonna give him a special medication through this one that is gonna cool it off, and it's gonna decrease the metabolic requirements. So that way we will have a still heart, decompressed, that you can do your connections, more control. The only drawback of this is that we are on the clock. Okay, so this has to be done fast because the heart cannot be stopped for too long. All right, so we have to do it fast. And the other one, when it's off pump, then we have all the time in the world to do it, right? Because there's no damage done. But here, it's a controlled situation, but we cannot linger on it. We just have to keep moving. Now, what are the approaches that can be done? This can be done through what we call open heart surgery or conventional sternotomy. Did you have the sternum here? We will make an incision here. We will open up and your heart will be sitting right behind it, okay? And we will make the connections with the cannulas or whatever configuration we decide. That is one way to do it. Also, we have done is minimally invasive, but not everyone is a candidate for minimally invasive. There are a specific subset of patients that will benefit from this and a specific subset of lesions, because you cannot do a quintuple bypass through minimally invasive, right? It's very challenging to do it. But you can do a one bypass or maybe two bypasses. So if that is your configuration, most of the time you are a candidate for this. So what we'll do, we'll just make a small 4 to 5 centimeter incision here, closing to your chest, in the front of your chest. And under direct vision, we will make the connection somewhere here in this area. We can use a robot, which we will use ports, 5 millimeter ports to bring the robot arms, and it's going to help us during the surgery. Or we can do it with an endoscope, which is basically putting a camera inside. All right, so there's many techniques for minimally invasive, many techniques to do it open. It will all depend in the what medical factors do you have, what is the anatomy of your disease, and all these things. All right, so not everyone is a candidate for it, but most people, I think, it will be a candidate for one or the other. What are the outcomes from this surgery? Number one, most common, infection. What are the most common factors for infection? Smoking, diabetes, obesity, previous radiation. All right, so these are 4 major factors. That's why we try to minimize these factors. That's why no to smoking if you're going to go through this surgery. Your diabetes, we have to control your diabetes. And radiation, you had it in the past, so we cannot control that. But these things that we take into account. The infection can be something big, like with a deep in your body, or it can be something small, like a little redness here in the incision. We just open up, put a little band-aid, and some antibiotics, and gets better. Infection rate is about 1 to 2%. It's not very high. Bleeding and the need for transfusion is very well described, with minimal invasive techniques and off-pump techniques being superior for bleeding and transfusion. But it's about, I would say 5% chance of having issues with that. Can you have a heart attack after getting bypass surgery? Yes, because let's say if the grafts go down, or if you continue to smoke, whatever we did with the surgery is going to go down. So you can have a heart attack, which is about 5%. Atrial fibrillation is when you have a normal heart rhythm because of the inflammation, irritability of your heart, some medication, some fluid. It's about 20% chance. Now, most of the time, this one resolves within 3 days. But if it doesn't, there's another subset of patients that will resolve within a couple of months. And usually it's treated with some medications. Very small amount of patients will be on this permanently. But it's one of the most common things, and we have protocols in place to try to prevent this. Can you have renal issues, respiratory issues? That is possible too. That's why it's very important to look at all the risk factors and see how we can improve those before you get to surgery, so we can get you through surgery in the best shape possible, all right, to minimize your complications. And about the neurologic deficits, there are 2 types, okay? So one type is going to be having, let's say, some mild cognitive impairment. Let's say you go to the supermarket trying to buy 3 things, you only remember 2. All right, that's one type. And the other type is having a stroke. The chances of stroke, depending on your risk factors, is about 1%. All right. And then sometimes it's a very low risk of stroke, but it's never zero. So I tell my patients it's never zero, but we have had many studies. This has been very well published about stroke, heart attack, and the possibility of death of bypass surgery compared to other techniques to restore your blood flow. And in general, for some patients, bypass surgery is still superior to other therapies. Can you die from this operation? The answer is yes. The chances of dying varies on your medical problems, but about 1 to 2% chances of that happening, either because of a big stroke, because of a big heart attack, big blood clot, and all these things. But even getting a haircut or getting plastic surgery, you can have issues, right? So it's not it's a low chance, but it's not zero. Now, what is the recovery like for this surgery? So in general, patients will stay, in average for minimally invasive, they will stay about 3 to 4 days in the hospital. For open surgery, about 5 days in average. Some people leave home on day 4, some people leave home on day 10. It depends how strong you are and if you need some sort of rehab, if you need help, or if there's any other complications that happen to the procedure. But in average, it's about 5 days in the hospital. Right? In the recovery, I will tell the patients you need 4 to 6 week vacation time, especially if you do heavy work, if you're a mechanic or you do some heavy physical activity on your day-to-day basis, then you will need 5 to 6 weeks of rest at home. When I mean rest, I don't mean like being in bed all day. I mean like not doing heavy lifting, not doing strenuous activity, but you can go out for a walk around the block a couple times a day after the surgery, and that's what we advise. All right? Some people will need some sort of rehab, especially let's say if they live alone or if they have a lot of stairs in their house or they need a lot of support, then they will put something for rehab so they can get stronger. And in that way, they can go back to the functioning status. In general, the quality of life improves a lot after coronary bypass surgery because most of the time you're going to be symptom-free, no more chest pain, right? No more shortness of breath. And overall, the survival is superior. So overall, the quality of life improves after this. And how about the follow-up? In general, I see my patients about 2 weeks after they leave the hospital, and they will see their cardiologist around that same time. For the long-term follow-up and managing the medications, usually with the cardiologist that will follow up. And there's any issues with the surgery or with the healing, then we will address those. But overall, we'll see them once in the clinic, make sure everything is okay, looking at the incision, make sure that they're recovering well, and to answer any questions. And if not, then they will just continue the regular follow-up. All right. So I think that's all I have right now. And, I hope this was instructive, and I hope I answer a lot of your doubts from this. I think it's probably a good time now to see if there's anything in the chat, see if anyone wants to share any questions or anything that we can answer for you.
Absolutely. I'm going to give them the opportunity to write questions. I just want to say that, oh my God, this was great. Your slides, your whole presentation was so thorough, but informative and to follow. It was great. And you really explained everything so well. I don't know how there could be any questions. We'll wait a few more minutes, but yes. I don't think you missed a beat here. No pun intended.
Yeah. Okay, let me see. There's something in the chat.
I think what we're doing is saying great presentation, and then Kathy's putting in your how to get a hold of you is what's in there right now. So that's really what it is. We'll wait another minute or two, but I really feel that you really just knocked it out of the ballpark. On everything, every way.
Wow. I appreciate the warm comment. I have to say overall, I think, a lot of patients are a little scared when they talk about open heart surgery, and with reason, right? Because sometimes if there's something that we don't understand and we're afraid of it. But, I would say, from our experience that 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 heart surgery overall is very well. It has evolved a lot, and to the thanks of many brave patients and many brave doctors, a few decades ago, it is what it is today. We're able to provide it to a lot of people.